Hi, welcome to Beyond the Table. And today we are here with oral surgeon Dr. Bradley Harrelson. He has his practice in Niceville. It is Bluewater Oral Surgery Center. And today we are going to dive into TMJ and a little bit about jaw health. Star Massage Co. has been really fortunate to be able to work closely with Dr. Harrelson and help clients and patients with TMJ. So, how are you doing today?
Doing great. Thanks for having me.
Thank you for being here. I'm super excited. So, tell us a little bit about who you are and why you became an oral surgeon, and just a little bit about your company.
Okay. As she mentioned, I'm Bradley Harrelson. I am currently an oral surgeon in Niceville at Bluewater Oral Surgery Center. I came about oral surgery in a long route. I was out of college 7 years before I even went back to dental school. I actually was in the ministry first and had a master's of divinity, was a youth pastor at First Baptist
That
Church
is
San
awesome.
Francisco, and then was running a charity dental clinic in Mississippi. Saw the way that dentistry could meet those immediate needs of patients and
Yeah,
got interested in it. I had thought about doing med school, so I already had a biology degree, so all I had to do was study up and take the dental acceptance exam
that's
and
awesome.
got in. But I was an older, more mature student starting dental school. Because I was an older student and I already had two kids, another kid born during dental school, trying to figure out a way for my wife to be able to stay home with the kids while I was in school. Found out about the Air Force Scholarship Program.
Oh, that's
So
really
applied for
nice.
the Air Force Scholarship Program, who gave a stipend and paid for my second, third, and fourth year of dental school, and I owed 3 years back to the Air Force.
That is awesome.
So did
That is
that.
really awesome.
Thought I would just do 3 years and check out the Air Force. Ended up doing 14 years in the Air Force.
It's a
First
big
five,
change
yeah,
there.
first 5 years I was a general dentist doing regular, fillings, crowns, root canals, things like a general dentist does. I had my IV sedation credentials, so I started doing a lot more oral surgery at a small base that had no specialists out in South
Okay.
Dakota, and became really interested in just kind of the overall effects of the skull in general, the muscles of the face on dental health and wisdom teeth a lot too, taking out
Oh,
wisdom
yeah.
teeth. So applied to a specialty program in oral surgery through the Air Force and was selected for one of those few people that got to do that. And they actually sent me,
Yes.
some go to an Air Force base for training. One every year goes to a civilian institution, and I was the lucky one that got to go to a civilian institution. So
That's
I did a
awesome.
4 year oral and maxillofacial surgery residency at the University of Texas in Houston, Texas, at the Texas Medical Center. Huge medical center. We covered like 6 hospitals. So when you were on call at night,
That's
you were on call.
that's
You
huge.
you
Yeah.
never slept.
I was gonna
Um,
say you're everywhere right then. Yeah.
exactly. And then after doing my 4 years of residency training in oral maxillofacial surgery and specializing in that specific aspect of dentistry, was stationed at Eglin Air Force Base just across the bay. And we fell in love with this area and had the
Yes.
opportunity to buy a practice in Niceville. So we got out of the Air Force after 14 years and bought a practice right in Niceville,
That's
a couple of miles from where I
awesome.
was living.
What an amazing story. It
Yeah,
all just kind of like fell into place for you, it kind of
exactly.
seems like.
Mm-hmm.
And I'm glad your wife was able to stay at home. Is she involved in the practice now?
She does help with the practice. She stayed at home while I was
Yay.
in oral surgery. I mean, when I was in dental school, and then she started working again after the kids started getting older.
Yeah.
Now she's actually a real estate agent, a realtor with Location Realty,
That's
and
awesome.
but also she helps out with the financial side of my practice, and she's kind of the brains behind the operation.
There you
And I
go.
just
There
treat
you
the
go.
patients, and she runs the business side of it. So she does two jobs now. She helps me, and she is a realtor.
Nice, nice.
Mm-hmm.
So, real quick, so have your kids showed interest in oral surgery or any dentistry,
Actually,
or
it's
have
funny.
you hoped for that?
I have three children, and none of them are going into dentistry.
Really?
So
That is
two of
hilarious.
our close friends, we have like three couples that do a lot of stuff together. And the funny thing is that one of their sons is in dental school right now, and the other couple's daughter is in dental school right now. So out of
Nice.
the three couples that always do stuff together, everybody but my kids went to dental school. So,
Nice,
um,
nice.
but one
High
of those
hopes.
one of those couples is a pilot for FedEx. Used to be a pilot in the Air Force, and my son is in pilot training. So
There you go. There you
I
go.
recommended them for dental school. Maybe he can recommend him for FedEx.
There
So
you
we'll
go.
see.
It works that way. That's why you got the friend circle. It
That's
goes
right.
around. So diving into like TMJ, and you have so much experience with the facial structure and the muscles and everything that goes into there, and you really seem to focus and specialize in that area and want to be able to help people with that. How would you explain TMJ to anyone that comes in and doesn't know anything about it? They're just coming to see you and just having aches and pains, can't really explain it, and they've been referred to you.
Sure. It is a frustrating aspect of dentistry and oral surgery. I will tell you that. I kind of parallel it to people when they come in to saying, like, most of the stuff we do in the dental realm is a problem and we fix it. You got a cavity, we put a filling in there, or put a crown on there. You got a bad tooth, a rotten tooth, we pull it out. Problem fixed. That's how most of dentistry is. Whereas medicine, you more manage. You have blood pressure problems, you have diabetes problems. You can't quite cure that, but you figure out ways to manage that. And I always tell patients, unfortunately, TMJ is one of those overlapping with medicine type of areas of issues that we can't really give a hard and fast fix to TMJ issues. Typically, it's something that you're going to have. We've narrowed down ways to do behavior modification, minor ways you can manage it on your own at home, supplemental things you can do. But even still, I tell people the frustrating part for me is I can't always give you a fix when you leave here. So that's a frustrating thing about TMJ. But I guess kind of to walk you through kind of what I would say if a patient came in and had TMJ issues. I kind of start by talking about kind of how the problem is, so they kind of grasp it. Like, you're probably not going to leave here, or even if you come to see me multiple times, with a fixed TMJ.
So you don't set them up with any, guarantees,
false expectations. So
for sure.
I basically kind of go through the biology of it, the mechanics of how the TMJ works. It's a very complex joint, and it's one of the most used joints in our body because of how we use it every day for eating and chewing food and talking and chewing gum. We'll talk a little bit about later some of the things that can cause issues. But I kind of explain to them, because people come in all the time and they say, I got the TMJ, or I got TMJ. I'm like, you have two of them. We all do. TMJ is not the problem. TMJ is and part of your anatomy. TMD, or TMJ issues, is more appropriately how you would say that, because TMJ, and I've got a few models here.
Tom and Joe.
Bluewater surgery hats here. We'll move those to the side. But we have Tom and Joe for the TMJ. And I kind of explained to people that the temporal part of TMJ is the temporal bone, which is here. And also we'll see on this one in a moment, the temporalis muscle comes up and attaches to the temporalis, to the temporal bone. So the T of TMJ is the temporal bone, temporalis muscle. The muscle you'll see here attaches to the coronoid process. There are other muscles that we'll focus on in a second that attach inside of here to the pterygoid process and to the mandible. And then there's another one, the masseter, which we see, which is a big problem in TMJ, is the masseter muscle, because that's what's one of our main chewing muscles, and when we can misuse that. But I explained to them that this is the T part of it, the temporal bone. The mandible is another word for the lower jaw, so that's the M part. And then the J is obviously any interface between a couple of bones in the body. So we have the T, M junction together with the J. So that's the TMJ. So I verify they all have at least two TMJs typically. I haven't found anybody with three, but then there is a little cartilaginous disc that's between there that kind of is the cushion between the lower jaw and the temporal bone, which sits in the articular fossa. Now, on a normal function, that disc is just cushioning between this bone and this bone, and it actually will slide with it. The disc kind of gives that cushion between the mandible and the temporal bone, and when you open, I explain to people the first 15 to 20 millimeters of your opening is simply called rotation. You're simply rotating in your jaw, like so. There's no movement down there. So the disc just sits right where it is. You usually don't have any problems with that first 10 to 15 millimeters. It's when we really want to open wide to get a Subway sandwich, to sing a song, to yawn, that we really have to dislocate that jaw a little bit. And at that point, it goes from the rotating to the translation, and it slides down. Now, this model is not doing it, but typically, ideally, that disc would slide forward with that to be the cushion. So 10 to 15 millimeters rotation. Translation is the second part of it, when we really open wide, and it slides down, but that disc slides with it. Now, the biggest complaint we get when people come in is, I got a click and I got a pain. The clicking and the pain actually comes typically from problems with this disc right here. And as the disc it's supposed to slide forward naturally as you do that last part of opening. If it gets inflamed because of misuse, overuse, or some type of disease process, it doesn't slide as well. And it can have some inflammatory products related to it. It can have like just fatigue and wear. And as it slides forward, if it slides in front of this joint as it's coming forward, people have trouble moving from the rotation to the translation. And if it gets locked in front of it, that's what's called the lock jaw. And there's two different types of lock, which you might have dealt with before when people come in. Is you have the closed lock, meaning they can't open past that rotation phase. The rotation is still no problem because they're in the fossa. So they can do the small opening, but they can't do the open for a yawn or a sandwich, and they get caught. The closed reduction means that the disc is getting caught in front of it, and it's trapping this from going forward. And they've hit a block. I like to tell people, just so they can put a picture in their mind of what it is. It's like, because everybody's had a rug that gets pushed under a door, or the welcome mat to your house, and it gets bunched up under the door. You go to open it, you're opening it fine, and then you hit the door, you hit the rug, and it stops. And I'm like, what do you do to open the door to the people? And they're like, well, I jiggle the rug, and then finally it pops past it. Well, sometimes you have to jiggle our disc, and you either do it just by, if it's not a bad catch, you can just wiggle your own jaw, and people kind of realize like, okay, I open, I catch, and then I have to do this, and that's just the wiggling the rug to get past it. When it goes past it, that's when you hear the pop and the click, because literally it is going past that disc, and now it's on the other side of it. If it doesn't go past it, it's called anteriorly displaced disc without reduction. So if it reduces with reduction, means you work yourself past it. It catches, but you work past it. Sometimes you can have it without pain if it's not badly inflamed, but typically people will have it with pain as it's going past, and when it pops and clicks, it also causes pain. Now, as they're closing, sometimes that disc can actually displace posteriorly. So you have an anteriorly displaced disc, or you can have a posteriorly displaced disc.
So is it going to leave? So is it going to leave the jaw just protruding, or is it going to pull that retraction back there?
Typically, if you have an open lock, that means it slips back behind it because of those inflammatory products and just the inflammation and wear. So as you go to untranslate and go back to this, it's same thing. The rug gets crammed up under there, and you can't go back. And if it's a bad one, that's when you have the people that freak out because they're like,
and it won't close.
And
they end up in the emergency.
And they're talking to me, I can't close it out. And sometimes they can actually, wiggle themselves. Sometimes they can actually, you picture it's caught here. So I'll tell people, manually pull your jaw down and then past it and back in, so they can relocate.
But some people, be so scary when you're stuck at home and you're just like, I can't.
Some people just get scared, and they will end up in the emergency room, and we'll see them in the emergency room. And sometimes it's so bad that we even have trouble like reducing it because the muscles have spasmed at that point. The disc is locked, and we may have to give them like some propofol, some sedation medicine to relax everything in their body, sedate them a little bit, and then we can, and also for pain control, and then we can pop it back in. And then we would usually have to put like a compression dressing around their head to keep it closed for a while, because if we didn't, it might pop right back open. That's the scariest situations. People, it's more scary to have an open lock than a closed lock, because
sounds like
you're
for
stuck.
sure.
If it happens to people a lot, they kind of get to the point where they can realize how to manage it. Just learn how to push it back, and we coach them through doing those type of things.
When it gets that bad, do you recommend like, hey, if you've done a few of these little things, now you need to just go to the hospital, because they've kind of worked themselves up into like the muscular structure, the skeletal structure, like everything's in a spaz.
And as we'll talk about a little bit more later, if the muscles spasm and the muscles are contracted, that's going to worsen everything in the situation. And with stress, even just walking outside with cold weather, if you've ever kind of tighten all your muscles in your body, you tighten up and you can clench your teeth too. So if you're getting stressed because this thing is trapped open and now you've overworked all your muscles, you can make it even harder. And then, so if you've tried multiple things, sometimes you do need to go seek some professional help to try to sedate you in some way. If you have some muscle relaxers for some other reason, or we prescribe muscle relaxers to her, you can try the muscle relaxers and see if after the muscle relaxers you can slide it back into place. But if it's still not working, sometimes you do have to go to the emergency room. I've only had a few that I've seen in the emergency room, but those people are pretty scared when they come in there like that.
I would be too. That's horrible.
Yeah.
And leading into the muscular structure, and leading into like, once you talk to them about this and some of the signs and symptoms like the clicking, and I know that when you do refer people, or I am referring them to you, I know that when they're coming in and I'm already letting them know that these certain muscles are really tight, or I'm hearing some of those signs and symptoms like the click, then I know that I can like, hey, you may need to go check that out there. But with that, what are some of the muscles that can be affected that you see?
Sure.
And kind of along those lines, and with these happening, and the clenching of the jaw, because I see that a lot, and also the grinding. And I try to let them know like those are affecting those muscles as well.
Right.
So like which muscles, if you can go through that kind of explain.
Kind of to jump off of that, I also tell people like there's basically two things that can be causing their TMJ issues. There can be the hard tissue, meaning bone, cartilage, or there can be the soft tissue, which is the muscles. But in most situations, you've probably found out as well, it's a combination of both of those things.
1000%.
Because one's triggering off the other one, or vice versa.
Yes.
If it's not the muscles and it's only the hard tissue portions of that, then a lot of times we do have to move toward things that just kind of put that jaw in a rest position, which we'll probably touch on a little bit later, like the occlusal guards or the bite guards can kind of do that. Some of it's just behavior modification and telling people you need to. I often will actually tell people, if I first see them as a patient, I'll say, it's going to sound weird, but get a journal, and during the day, whenever you have the worst flare-up of the day, write down what you were doing right before that happened. Don't wait until later in that afternoon and try to think about it, or later that night to recap. Like, keep it with you. When it gets bad, write down what was I doing right before this happened, because typically you can find those things that are triggers for you that was making you clench.
That's a great idea.
Typically, any joint in the body can be misused, even if it's working fine and working well.
Absolutely.
Like my professor used to always tell us, like, if I have a perfectly good knee joint, but every day for my job I carry a 90-pound bag of concrete up and down the stairs, even if my knee's working great, it's going to get some overuse and some wear and tear. Somebody can have a great jaw. There's no actual disease process in there, but just the normal wear and tear of them usually doing parafunctional habits, meaning our jaw is made to withstand the forces of chewing, but we do other things besides chewing. And a lot of us do it a lot during the day. And if we're clenching, if we're grinding, if we're chewing excessively, like chewing gum too much. One patient that came in, and I was going through the list of questions with him, and he was like, he's a lawyer, and he's like, a patient kind of like, he had paid me, but they also kind of bartered with me, and they gave me a bunch of homemade beef jerky that they had wrapped in something vacuum packed. And I was working late at the office that weekend, and the whole time I was just eating that beef jerky because I couldn't go out.
Oh my God.
And I was grabbing at my teeth and opening it, and then the jerky was tough too. You think that could have messed up my jaw? And I'm like,
1000%.
I think that could have messed up your jaw.
1000%.
Stop opening beef jerky with your teeth. But things like beef jerky are even things like that you don't think about it, because we think stay away from hard foods, but chewy foods like a sourdough bread or a sourdough pizza crust. It's
sourdough
soft.
Has my heart.
It's soft, but when you think about having to tear it, that tearing motion can put strains on that. And it can even like torque it, like as you're tearing, it can torque it like so. And that's why we call it parafunction, because it's not the normal function that the jaw is made to support. It's something outside of that, meaning parafunction. And it can cause some issues to that. When I'm teaching patients about this and walking through, I tell them, like, how many times a day do you think you keep your teeth together? And people are like, all the time. But technically, we should never have our teeth touching together during the day. The normal rest position of our body is to have our teeth 2 to 3 millimeters apart. That's not a lot, but it's a little bit. And if the 2 to 3 millimeters apart, this joint that we talked about is in this rest position, meaning it's hanging passively, it's not engaging the muscles, it's not pinching that disc between the two bones, it's hanging passively there. Our lips can be together. I tell patients you don't have to look dumbfounded all day, like, walk around like this, but our lips can still be together and our teeth can be apart, and it puts it in that natural rest position, which is the ideal balanced position for both the muscles and the joint. It's not pinching the disc, it's not crushing the disc, it's not engaging the muscles. And I also tell them, like, you're in the gym and you're walking around flexing in front of the mirror, the longer you flex, even if you're not lifting weights, you're flexing, your muscles are going to get sore, and you're going to have some function that's not the same. So we can do the same thing for our muscles. Just the biting force engages those muscles. And so if they're not in the rest position, I'll tell them, when you journal and you find out those things that are triggering you, which can be a plethora of things, A lot of times, you know, people are driving between here and Crestview on 85.
Oh my gosh.
All the bases let out.
Yes.
They realize
traffic will get you.
Punching in traffic.
Yes.
A lot of times people doing big projects for work or for school, the longer you look at a computer screen, you start really focusing and you don't
1000%.
know it, but you're clenching your teeth.
Even when I'm in here working on patients and clients, and I can feel myself, and I have to remind myself, like, wait for a second, you know, just let that
most
go,
professionals
because you
do.
get in the zone. And even when you're probably like bending over and all these positions, and you know what to do, and you still find yourself like.
So I find myself clenching all the time. The more focused you get on a project, you're so focused, you forget, and you're clenching your teeth, and you're engaging those muscles, and all that stuff's going, and you're crushing that, and that's what causes the inflammation. Is you're crushing that disc, which leads to the not sliding like it should be, and getting that displacement with or without reduction.
Yeah.
So I tell them, like, think of the things to rest, and it's a silly little mantra I tell them. I was like, when you find it, if it's doing a computer project, if it's driving, get a sticky note. Put it on your speedometer.
Open your mouth.
Put it on the side of your computer and just say lips together, teeth apart. Lips together, teeth apart. Because if you just say it a few times, you're like, okay, my lips are together, but my teeth are not apart.
Yeah.
So I need to do lips together, teeth apart.
We got to do a little jingle.
Yeah, because even when we're chewing our food, there's technically the teeth aren't going together. If the food's between them, it's got a bolus of food between there that's keeping them apart. So really, ideally, through the day, our teeth should never be in that clenched position. But most of the population keeps it clenched. And then at night, we can't really do the lips together, teeth apart mantra at night. We can't put it on the back of somebody's eyelid. So at night, it's out of our control. It's in the subconscious. And that's when we move into some other, like, you know, supplemental things that they can do, like an occlusal guard, a bite guard.
And that will help with the grinding and some
it helps with the grinding
that they have.
So it's like a mouth guard we put in there. It usually doesn't cover the whole tooth, but it's a hard guard on the with a flat surface. And you usually just put it on either the top or the bottom. A lot of times we'll do it on the top, and it fits to the teeth. And then the bottom part of the night guard is a hard plastic that's smooth.
Okay.
And when I talk to patients about this, I just kind of say, you know, if your teeth are rubbing back and forth like this, there's peaks and valleys to those teeth. It's banging up and down, it's crushing the joint. It's banging those muscles up and down. It's aggravating those things, and it can cause a lot of tension. And if you're doing that all night long like this, now we can't stop you from that subconscious movement, but what we can do is we can create a way that if you're going to move, we're going to make it kinder to your jaw, to your joint, to your muscles, and it's a smooth surface to go on. And I like to make up like little analogies for patients because they tend to remember things better. So I got the rug jam, and this point I talk about if I take my car and I drive 30 miles an hour down a freshly laid asphalt road, it's going to do one thing to my car. The shocks are not going to get messed up. The tires are not going to get messed up. If I take that same car, drive the same speed, 30 miles per hour, but I'm going down a gravel road with potholes, I'm doing the same thing in the same car, but it's like doing like this all the way. The shocks are messed up. The tires are messed up. So I tell people, this night guard is like freshly laid asphalt. You're still going to move around, but it's going to be over a smooth surface. It's going to be kinder. And the other thing that the night guard does is it's about a 2 to 3 millimeter thickness. So we've already mentioned that we want that 2 to 3 millimeter rest. So it forces you to be in that rest position because you can't overclose. So it does two things. It provides a smooth surface for the grinding that you're doing subconsciously, but it also provides that 2 to 3 millimeters so that joint is not being pinched all the time. And even though you are moving the muscles, they're just moving laterally usually and not clenching together.
And then you have those extreme cases where some people try to like eat it, or they like bite so hard into it.
Some people have trouble with night guards, and they'll just in their sleep. They'll like, I took it out and I put it on. I woke up the next morning and it's on my bedside table, and I don't remember taking it out. We said sleep apnea is another thing, but we've seen people that wear CPAPs or wearing appliance to bring their jaw forward for sleep apnea. They'll be like, I tried, doc. I'm subconsciously taking it out and I'm putting it there. And then if you have a dog in your house, some reason
you're done. The
dogs love human saliva mixed with acrylic, and they will chew that thing like a chew toy, and it doesn't fit in your mouth as well as after the dog has worn it in his mouth. So that's just something that is an issue that even though we try some of these supplemental aids, some people just can't tolerate them.
And I loved how you touched on behavioral things as well, and moving into like even just saying like driving through the traffic, because I do find that that carries So like kicking in all of those muscles. So everything that you're flexing, it's almost coming from the jaw or even vice versa. And it kind of all leads back to here.
Exactly.
When that chest gets tight, when you're holding all this tension, and to here typing and you're just stuck in these positions. And I don't think people realize as much that these are affecting so many other things.
And then people with just to have chronic pain for some other ailment, maybe not in their jaw, they have chronic back pain, chronic muscle pain in their legs. When you're carrying that tension, you'll begin to realize that I'm carrying this tension by clenching my mouth.
Yes.
The pain started down here, but this is secondary to it. And that's one thing, just getting a massage for any other part of your body can actually help this, because it relaxes everything and you kind of take that away. But and those big muscles that we're talking about, or this is the temporalis muscle, the big one that kind of fans out. This is the masseter muscle, so it connects from the upper jaw to the lower jaw, which is the primary workhorse in our chewing. And when we're clenching, like we're talking about, you're squeezing together, you're totally engaging this muscle and all those muscle fibers. It's not made to be working like that. It's made to simply chew up and down. And then when you're in that rest position we're talking about, that muscle's then it's relaxing. This lower jaw is just hanging there. But if we're clenching or we're grinding or we're just closing together, we're engaging that. There's some other muscles on the inside portion, the pterygoid muscles. This diagram doesn't have the lateral pterygoids. They connect here to this part of the jawbone, and then the medial pterygoids connect here. But that's another muscle that can cause a lot of issues, that people have pain on the inside of their mouth for those muscles. And if we're overusing these muscles, just like we said, any other muscle in your body that you keep flexed all the time, it's going to get sore, it's going to cramp, it's going to spasm, and you're going to have issues like that.
So have you had the experience where they come in and they're saying, yes, I have this, but I have so much neck pain, I have so much pain in my shoulder, or pain over here, and you're sitting there and you're like, this is why.
Yeah.
Are you and at what point, so after you see them and you are treating them and you're doing what you need to do, and the night guards and things like that, and you see that they're still kind of suffering and coming back, at what stage do you recommend, hey, I think you should go get a massage for this? Or do you talk about TMJ massage?
I usually go right to the massage. I'm very quick to go to the massage, because I just kind of, and people are like, I'm paying to come to the dentist and the oral surgeon, you're sending me somewhere else. But it's like, your biggest problem is coming from muscle tension and from misuse of your muscles, which is then indirectly affecting the joint space as well. And TMJ, it's a very complex joint. So we want, when we're working with a TMJ, we want to start always start most conservative to the most invasive.
Okay.
Because once you get to these invasive mechanisms for treating the TMJ, you can get past the point of no return, and you can cause some issues. The end all is a total joint replacement, just like you get a total hip replacement in your hip or your knee, where you go in, you actually shave off the top part of this jawbone here.
Oh, that's intense.
And then you put a titanium joint, and you put another titanium lining here to replace this disc, and they have a prosthetic joint. So obviously, if you get to that point, that's the most invasive, because you've actually shaved off a piece of the jaw that's not going to come back anymore, and you're relying on that titanium to do that. So we stress conservative first. So first thing I'll start with the patients always is just the behavior modification. Let's figure out what your triggers are, and let's figure out ways you can, alter this behavior a little bit to see if that helps it out.
I love the journaling.
And I tell patients, the journaling to kind of figure out what it is, and then once you have it in the journal, how can I work with that? I tell patients all the time that you are a big part of this process. A lot of other things, as I said, we do. You come in, and then I could do everything, but now this is one thing that I need some help. And then also the patient's a big part of the process. Like,
absolutely,
I can't just fix everything here in the clinic, and you go home and you do all these things you were already doing every other day before you see me again. You're going to have those same issues. So we have to coach them through those things to do. The behavior modification, I tell them, think about what you're eating, your diet. Like, do you have a lot of hard, crunchy foods? Do you have the sourdough pizza that's really chewy, that's aggravating it? Do you chew a lot of gum? Maybe you need to stop chewing gum. And they're like, I love my gum. Suck on a
and
mouth
that's usually
freshener.
Like a nervous habit as well. Most of the time, it's something they have to have. That's like a nervous habit they have to keep doing, or something like that. So that's something else they can be like, Hey, I'm eating a piece of gum every
Yeah.
time my kids aggravate me, or every time I'm
Exactly.
sitting in traffic, I'm eating
So
3
find
pieces of
something
gum.
else to do to
Yes,
take that stress away.
absolutely.
And that's the other thing I tell them is like, you need to get the stress out of your life. Figure
Yes,
out a way to deal with the
absolutely.
stress that's then indirectly making you clench and do those things. So we start with the behavior modification, diet modification. Also, caffeine. Too much caffeine can actually
Ooh,
aggravate it and exacerbate the situations
coffee
too.
drinkers.
So the coffee, the energy drinks, cut down on those things
Yes,
because they can really cause
yes,
a lot of issues there, and people don't like that advice either.
yes.
So I'm taking away their gum and their coffee, and they don't like that.
Then they never come back to see it.
But then I quickly move into, I kind of talk a little bit about the occlusal guards. And so we could think about talking an occlusal guard, but usually the first step I do is I recommend considering going to a massage therapist.
Perfect.
And I see that. And some people will say, well, I already see a chiropractor, or I already see a physical therapist. And I'm like, well, you need to go to Casey because she is got a special TMJ massage. And one of the things I always tell patients is that if you don't know, she's got a nursing background, so she's a very smart person. She's very educated. She knows these muscle groups that we're talking about, and as she goes through the massage, she talks to the patient about why she's doing what she's doing. Which again, like I said, a lot of this with the patients is me educating them, you educating them. They're hearing it from two different directions. And I met Casey, and she told me about doing the TMJ massages, and I was going to start recommending patients, and then I'm like, before you send your patients to somebody, you want to kind of see, is this person legitimate or not? So, and I know, as I mentioned, I clench my teeth at night. I clench my teeth when I'm working, so I have TMJ issues too, muscle issues. So I was like, I'm going to try it out myself. So I came in, and I mean, she gloved up. She massaged muscles inside of the mouth. She massaged muscles outside of the mouth. She gets the trapezius. She gets the sternocleidomastoid. She gets the upper pecs. All that for a TMJ massage because, as she mentioned, everything is linked together. Yes. And if you just focus on one part of it, that same tension is going to be pulling on that.
1000%.
But I think the biggest thing is I tell people, like, she'll put gloves on and she'll massage the pterygoid muscles inside of your mouth.
I love that you showed the inside of here because I was like, no one does that.
Yeah, there's a lot of chiropractors and physical therapists and other massage therapists that they don't go inside to get the internal components of it. And I thought that was one of the greatest things that I kind of brag on patients about it because I was like, she will actually do a TMJ massage. It's not just a massage mask of a TMJ massage. And as I said, she walks through what the muscle groups are, why she feels the trigger points are tight in certain places, and she'll check that, like I said, the sternocleidomastoid, the trapezius, the upper pecs, and all those things. And you really do a great job of educating the patient. So
I appreciate
and she helped me, and so I pass it on to my patients. And so usually the first step, I talk about behavior modification, diet modification, and then before they leave that first appointment, I recommend that they consider. And even if they say they've got a chiropractor or somebody, I was like, I've been to this person personally, so I can't vouch for your chiropractor or your physical therapist, but I can vouch for this person. And I usually try to get them coming this direction.
Thank you. I love that. And that's exactly why I put this podcast together, was because I want to let people know how we complement each other, how all of these healthcare systems, because each one will say, well, I have a chiropractor, will I go to my oral surgeon, will I do these things? That's amazing. But if we can complement each other and we can continue to bounce off and keep educating everyone about these differences, because even when you say, because I even went to see you, and that's how we met, about my jaw, and I was so excited about how open you were to, when I was running through the things, like, I know something else is wrong because I've done da 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 da. And when I said, like, I massage the inside of my mouth and I've done all the TMJ care on myself that I can do, and you were like, what? Why did you awesome, yay, my job's done. But you were so open to discussing those issues with me and saying, and interested in saying, like, well, do you do that? And continuing, because you were already thinking this could help my patients in the future.
Exactly.
And just meeting you was so amazing for me, because you brought so many opportunities, and just being able to have the people that are here that haven't heard of you and be able to refer back to you, and colleagues like yours that have just been really awesome. And you actually invited me to one of your events, and I thought that was amazing to have some people that you just gather with and be in there to just kind of open their eyes too, and go in and explain everything that I'm able to do and to help people further. And how do you think that event with your partners and your colleagues and just having their eyes open a little bit? Did it change anything for them or how they viewed things and their patients?
It was excellent. What she's alluding to is we have a study club once a month, typically on a Tuesday night, and several dentists and specialists, general dentists, different specialists like orthodontists, periodontists, oral surgeons. We get together and we have a study club, and we'll have a topic we talk about, and we eat together and talk, and then we'll just share, cases. So a lot of us are in a practice by ourselves, so we don't have anybody to like throw things off of. So it's a kind of a nice way to get together. All of us face TMJ issues with patients because they always come in and they're like, I've got problems with my TMJ. And as I said, it's frustrating for us as dentists because we got into dentistry and oral surgery because we like to help people.
Absolutely.
And often we feel like failures actually with TMJ issues because that's one of the big areas where we feel like I cannot always help you.
It is.
And I may do the same thing I did for the last person that helped them, but I can't guarantee it's going to help you. And so it's frustrating for us. And another thing alludes to the fact of what you were talking about earlier is a lot of times people are pushed off for that reason because they go to different dentists. And I got a TMJ problem because they can't fix them with anything. Oh, you tried a night guard? Okay, well, I can't do anything else.
Yes.
And sometimes, because this is typically related to stress, they just need somebody to listen to them and somebody to talk to. And if you take the time to listen and talk through the mechanism of why it happened, some just tips that they can do at home, then those people, they feel heard. And it makes a big difference, like, because everybody else just said, like, oh, I can't help you, get out of the door, go somewhere else with your jaw pain. And even if I can't help somebody, if I can kind of listen through, my staff hates TMJ consults because I stay in there so long, and they're like, we got a lot of patients in the waiting room. But and then when they come to you, I know also you, from being here personally, I know you talk through those issues, and so they feel listened to again. And it's nice for us, and that's one of the things I was telling these other dentists in the study club is we can't always do something to help it. But we want to be available to our patients, if nothing else, for a resource to give them another way to not point them out the door, but to point them down the road, across the bridge, somebody else that may help you.
Yes.
I can't help you, but I know somebody that can, and that person still feels listened to, and they feel, helped in a way that you didn't help them personally, but you could point them towards a source that could help them in a different way. And that's why I wanted to bring you into that thing, was to try to show them, and then like saying like, because a lot of times they'll refer their patients to me, and basically all I do is I listen to the patient for a while, and then I refer them to you. So I was like, we could cut the middleman out of this if you want to, and you guys could just refer them to Casey, but I knew they would want to know who you were as well. So she was kind enough to come out all the way across the bridge to Niceville, and we met on a Tuesday night, had some pounders, and
it was amazing.
Then several dentists and specialists were together. She talked through kind of what she would do with the patient. She got us an example. It was easy to get volunteer dentists to do that because, like I said, we all carry our tension in our jaws and our necks. And we are always contorted in weird positions while we're working on people. And so we got a lot of muscle pains and aches anyway. So there was easy to get a volunteer. And then as Casey walked through that volunteer dentist on what she would do to a patient, she was teaching everybody else. And then quickly the line grew, and everybody wanted massage. And they're like, this is the best study club we've ever had. And so there was one guy that had never got a massage his whole life, and he was like, I'm going to start booking massages every month. So, but yeah, we realized that at dentists too, I think a couple of dentists, so they're just kind of like,
they have,
not necessarily TMJ massages, but just kind of
for themselves, because you
for
need
themselves,
it.
because we realized like, wow, this is very good. It's not a luxury. It's something that helps me do my job better because I'm dealing with these muscle aches and pains. And they also referred patients. So they refer themselves and they refer patients. So, but that's why I did that, was because I knew as a health professional myself that loves to help people and just goes home to feeling defeated if there's something I can't do to help somebody, that at least I can show them another person that they could send to. And I appreciate you for coming across the bridge and doing that. It was, as I said, they said the best study club of the year.
If you could design your ideal treatment plan, how would you go about it? Like, how would you blend all the things together, and just kind of like from how we discussed before, the most conservative measures to the most invasive, if you want to kind of go through how you would put that together?
Sure. So as we mentioned, I always work from conservative to less conservative. Behavior modification, diet modification, consider massage. And then we'll begin to talk a little bit more about those two different components. Is it muscle related? Is it joint bone related? Cartilage related? Or is it a combination of the two things? And one of the things I'll start first is because typically most cases are muscle related in some form or fashion. At least they got a muscle component to it. So I'll talk again about how they can overuse these muscles, and I can offer them just a home prescription of a muscle relaxer and say, let's try the muscle relaxers for a while, see if that takes some of the tension off. And if the muscle relaxers are beneficial, then we can talk about the next step. Now, another thing I will tell them about the muscle relaxers is often I'll give them some at-home exercises as well. For instance, like putting their finger on their middle finger on their lower canine, their thumb on their upper canine, and then using the scissor action to kind of open their mouth more, doing physical therapy at home. Like they don't think about doing physical therapy for their jaw, but it's like if you had any other sore muscle or sore joint, your physical therapist is going to tell you to work it out. So work that out. And I would say if we do muscle relaxers, I would recommend taking the muscle relaxer before you do your nightly exercises just to loosen things up a little bit. And then if they do get benefits from the muscle relaxers, then they come back to me and I'm like, okay, if the muscle relaxers were beneficial, that does kind of confirm that there's at least a muscle component to this.
Absolutely.
One of the next things we could do, it's a little bit more invasive because I'm going to have to do an injection, but I could do Botox injections.
And with Botox, you do have to wait 2 weeks before you would come and get a TMJ massage because the Botox does have to settle and make sure that we give it that time to do that, because when I go in and do the massages, I'm doing the entire face and all of the muscles. So we always want to make sure we wait the 2 weeks before.
That's a great point.
Come to me. Yeah.
And that's something that I need to tell my patients before I send them to you.
We do tell you here.
I'll try to remind them that if we do Botox, wait a couple of weeks before you do that. Because as she said, the Botox can take a little while to settle in. If she's in there like manipulating it, it can send it somewhere else. But Botox, just like for paralyzing facial muscles to get rid of wrinkles, we can literally paralyze this because we cut it out, the neurotransmitter that's sending that signal to the muscle to contract. The Botox botulinum poison blocks that receptor, so it doesn't do that. So your muscle is not going to have as much stress as it normally would, and that's strength. So we can kind of paralyze those muscles a little bit. I do have to warn people that while this is not technically a surgery, I am injecting a substance into your muscles of your face. I'm using the needle to inject into your face. There are a lot of vascular structures. There's a big nerve that comes out right under it comes out of the brain back here, and then it comes out here and it fans out like 5 fingers, and it gives a facial nerve, and it's got 5 branches that do the muscles of facial expression. So we always have to caution people that just like if you got Botox for your wrinkles, if you're giving Botox in the face, you could either the needle could nick the nerve, or just the paralytic gets too close to the nerve, and you may have a little weakness on one side compared to the other. So we have to go over those risks with them. And now I'll go over the risk of don't get a massage too quickly. But one of the big places we would do is we find some of the trigger points in that masseter muscle. A lot of times we'll find some trigger points up here, and I may give some Botox injections in the temporalis muscle as well.
Will that help reduce signs of like migraines and tension headaches?
Exactly.
That is caused by the TMJ.
A lot of the headaches that come as these headaches that are TMJ related are because of the tension in this temporalis muscle. Because you can see, obviously, it fans out over the whole side of your head. So you'll hear these patients going like, I have a headache that just goes from here to here. And we're like, in our minds, we're picturing, of course it does. There's that muscle from there to there.
Absolutely.
So we can put some paralytic in that muscle. A lot of times we may give some of the same muscles I talked about her checking on me, the sternocleidomastoid, which goes here. I'll give some in the trapezius in the back and give some of those. Now, the big thing I have to tell patients with TMJ, because sometimes people say it's only the right side that hurts. Well, some of the things I can only do on that one side. If we do Botox, I tell people, even if your left side's not bothering you, I'm going to have to give you Botox injections on both sides.
Or overcompensation, right?
Well, yeah.
A lot of that.
Because if I paralyze this muscle and I didn't paralyze this muscle, now this one's going to overuse it. You're going to have problems over there, or your face is going to, close in a different way when you're closing your teeth, which will make this side hit earlier than that side, and you cause more problems. So that's one thing I say, like, I'm not just trying to sell more Botox units, but I have to paralyze both sides to keep your head balanced in those situations. So that would be one thing. But if they didn't get any benefit from the muscle relaxers, I'll say, like, I don't think we need to do Botox, because if they're not helping you at all, then we don't necessarily need to put you through these Botox injections, because you're probably not going to get a lot of benefit from that, because it may be only joint, bone, cartilage related type of things.
Absolutely.
And if it's that, or if it's a combination of a little bone and a little cartilage, then we recommend another procedure, which is a little bit more invasive. Still not technically a surgery. I'm not cutting their face, opening it up, but it is more invasive because we try to do an injection. It's called an arthrocentesis or a joint washout. Just like you can get an arthrocentesis of your knee or your shoulder, it's a washout of the joint. And we talked a lot at the beginning about inflammatory products that get in here. And you can have some just inflammatory debris that's in there where that disc is all inflamed.
Absolutely.
And if that is in there, it's good to wash those things out of there. This is a little tricky, this procedure, because we're aiming for the joint space, which is a super small space between where this connects to that in this enclosed capsule where the cartilage is. So I have to take, an 18 gauge needle, which is not a small needle. And we would usually do this with the patient sedated, because while I do it, I also have to manually manipulate their jaw. We call it manipulation under anesthesia, where I'm really working their jaw more than they have in a long time to break some of those adhesions in there. And also, as I manually manipulate it, it helps me kind of get where this is. But what I'm actually doing is I'm aiming that needle to try to go between this bone and this bone right into that joint space. And the way that we do to make sure it's in there is it's a enclosed capsule. So what I'll do to make sure I'm in the right spot is I'll fill the syringe with air. And then if I go in there and I push it down and there's no bounce back of that, then I know I'm not in the joint space. Yeah. If I'm truly in the joint space, when I push it down, that air has got nowhere to go but back into this. So I'll take my finger off and this thing will just start to ride back up, because all the air that I pushed in has got nowhere to go but back into this little tube. So that's how we verify that we're in the right position there. So I do an inflow port, and then I will take another needle and I'll do an outflow port. And I have to do the same thing to verify I'm in place. But then once I'm in place, I will take the syringe off of that second needle so that it's literally just an exit port.
Yeah.
I will take sterile saline, not tap water, because we're going into the joint space. So it'll be sterile saline, and I'll just flush this out with several cc's of fluid in here. And I'll go in there while that other exit port is there. So everything that goes in now, it goes around the capsule space, and then it exits out of this.
Oh, wow.
Makes a nice mess down in her shirt.
This is where everyone asks for my card.
That's right. Because at this point, I also have to tell them the risk. The same risk of the facial nerve is there, and they're thinking about this big needle going next to their facial nerve. There's some pretty big blood vessels that go right in front of the ear that I have to tell them about that could be nicked.
Oh, wow.
The eardrum is right here, which is another point. Yes. A lot of people have ear pain. Yes. That's actually TMJ pain, because look where the ear canal is. It's right in front of that.
Actually, when they come in for the TMJ, I include lymphatic drainage, because I always say, your ears are probably clogged. Yeah. And they say, yes, I feel like I can't hear. You sound so smart. Yes. And then afterwards, and I say, well, I'm going to add the lymphatic drainage, and I explain why. Because of the backup, all of this has caused. Yeah. So that just goes into like you having to debride what's stuck in there. And I explain to them all of the time as well, like when I go in and I have to do the intraoral massage on the muscles on the inside of the mouth, you may feel like you have like the massage flu, I call it, the next day, or you may not feel as well, because all of those things that were stuck in these joints, lactic acid, different things that just get stuck in there that your body may produce, or medications, things like that, may all need to recirculate. And it's just going to recirculate in a larger amount, and you just got to flush it out. But it makes you feel a little icky, I say, and it's just the way the body has to work itself out.
Because everything is very close to this joint. It's a very complex joint. So that's the ear canal right there. The tympanic membrane is right inside here. This is pretty thin bone here, and it's a pretty big gauge needle. So I have to warn people, like, as I'm sounding the bone to try to find, I literally have to sound the bone here, and try to slide between those two. It could potentially go in an errant path right here, and it could rupture your eardrum, tympanic membrane. It's a very thin layer of bone between there and the medial cranial fossa, which is, where the brain sits inside of there. Yes. So that's less likely to happen, but you have to, when you go over all the risks, it could actually go up into that and cause a violation there. If it slips out while we're doing all of the cc's of fluid, sterile fluid going in there, then all that fluid can dissipate into this, or transfuse into this tissue out here, and people will tend to leave with like a large...
Yes. Absolutely.
And then I'll put a compression wrap on it, and it'll dissipate over time. But you just have to warn them of all these things. And as she alluded to, once I go over all these things, they may have turned her card down at the beginning, but while I go through this explanation, they're like, on second thought, I'll take that card and try it out. So if nothing else, this is the way to steer business toward Star Massage Go. But if that's something I do, and then usually at the end, after I've washed it out, and we feel like we've got good drainage out of there, the inflammatory products, I'll take that exit port out, set it to the side. I'll put a little, gauze over that to cover up that hole. This one's still in here, and then I'll, change it out, and I'll put like a Kinalog, some type of steroid injection. And while it's still in place in the joint, I've closed it up, so this is going to stay in the joint space because I've closed up the exit port, and then I'll just give a little Kinalog injection, some type of steroid injection into there. You can actually do platelet-rich plasma, which is where you draw some of the patient's own blood. You run it in a centrifuge. They use it a lot in joints for knees and things like that, and it's got a lot of growth factors in there, healing factors, and you can put that into the space as well. Or hyaluronic acid, you can put that in there as well. So there's different things you can inject in there, but typically we'll do like a steroid just to cut down on the inflammation. So those are some things that we can do that are a little bit more invasive. And then if all those things fail, or the patient decides some more, or our imaging or x-rays showed actual arthritic degeneration, because you can't just have arthritis of the joints, just like any other arthritis of the joints in other places in the body, where it's just degenerating. The disc is degenerating, and what we see is bird beaking. That's what we call it, because instead of it being the rounded condyle like this, like we want it to be, it's shaped more like a bird beak. Ooh. And you can imagine this sits in the fossa and rotates in a certain way, but something that looks like a bird beak, it doesn't work as well. And so in those cases, sometimes you have to do a little bit more of intra-joint surgical stuff, where you're flapping in front. And then the last scenario, like we said, is the total joint replacement. We move from those cycle of things all the way there. I don't personally, since residency, I don't personally do any of the intra-disc surgeries, like the joint replacement or anything like that. So if it got to that point, I would typically refer them to an institute of higher learning, like the University of Alabama in Birmingham or the University of Florida, where there's the staff of the faculty that can do these things more often to do those situations.
That's wild.
But that's kind of the hierarchy of events that we go from least conservative to more invasive, and all along the way trying to steer them toward massage.
Try to. I love that you came in here. I'm so excited that we had you today. This has been so educational, and I'm so excited we're bringing so much light to everything that you do and how we complement each other and can help patients move further. And so now we're going to move into capping this out, and we're going to move into some fun questions.
Okay.
Now, you do this all day long, and you're in all these awkward positions. What are things that you do in your personal life to just relax, to make sure that you wash off the day, wash off the week? Because I know that trying to help people do take some of that home as well, and being so caring and empathetic about having, all of that into your work and all the passion that you have with it, because you can feel that when you come and see you, and you know that you truly care for your patients. And I just admire that so much. And so what do you do that you just do every day? Like, I got to do this, or I know I'm going to be offbeat.
I try to work out, just to kind of, work those muscles, get some stress out there. There's a funny thing about that. Some of the people that specialize in this, joint specialists, talk about, there's a fine balance between overuse of a joint and a muscle and no use of a joint or a muscle. And you can actually get bad results from either overuse or underuse. So it's finding that balance between overusing it in weird ways, but then not just going home and just not using it at all. So, trying to work through some of that stuff. So I try to work out at the gym at least three times a week, and do some cardio as well. I used to see massages as just a luxury, and maybe on an anniversary, get a couples massage for my wife or something like that. But recently I have become a faithful once a month massage client of Casey here at Star Massage.
We brought him kicking and screaming, but he stayed.
So and I found that that does help a lot. I'm not always as compliant as I should be. They always say nurses and doctors and therapists are the worst patients. So when she does find something that I need to work on at home, she's great about recommending stretches, sending a link to videos of things to do. Not always the best about doing those, but at least I'm trying to get here once a month and kind of do those things.
At least it's there. So if you were not an oral surgeon, what would you do?
Well, I mean, I used to be in the ministry, so I still do a lot with the ministry, but I like to entertain people as well. So every now and then, I happen to do a little juggling. So let's see if we can pull this off here.
We got it.
Needle is capped for safety purposes.
Yes, for safety purposes. Yes! That was awesome. Well, here on Beyond the Table, we believe in healing happens in layers. And if you could leave our listeners with any one piece of wisdom, insight, or practice that helps you stay grounded in your everyday life, what would it be?
Well, as I said, I'm a minister first and foremost. I was in the ministry before. I have my master's of divinity. So I always try to like keep myself grounded and just kind of looking at the bigger picture of things and thinking about, and being in healthcare, it's just a mystery and a miracle to look at how the body works and how God has created us in such a way that things can work together. So I always fall back on my faith in God, and then just kind of almost like meditation times of thinking about, okay, this is, maybe I had a tough patient, maybe I had a tough situation go on, with something else that's going on financially in life, but like this too will pass. The bigger thing is my relationship with God, my relationship with my family, and how I can serve those around me and kind of focus on those things. Another thing that I tell patients to do sometimes is just like breathing exercises. Like just center yourself and take a moment, especially when I'm doing oral surgery procedures, not even related to the jaw, but people just they get that panic mode, that panic attack, and they're just taking small, shallow breaths, and they're not perfusing their brain with oxygen like they should. And so you just have to say, like, okay, let's just slow down.
Yes.
Let's focus on what's going on here. Let's breathe all the way in, hold it, and then exhale all the way out. These shallow breaths are not helping you. And there's actually a breathing mechanism that can help with their jaw. And like I tell people, like, put your tongue on the roof of your mouth and inhale all the way in, and then drop your tongue to the floor of your mouth, which naturally makes your jaw drop into that rest position, and exhale with your jaw on the floor of your mouth. So you inhale, roof of the mouth, drop it, and exhale, and it opens that jaw, relaxes it, and then the breathing is just good for blood perfusion and for centering yourself and focusing on the bigger picture.
I love that.
So those are some things I would recommend.
Yes. Well, thank you so much for being here and sharing all of your knowledge with us today. And thank you to our listeners for joining us today. And be sure to subscribe for any other conversations that we may be having. Thank you for joining us at Beyond the Table. Have a good day. Yay!